This week on the BackTable podcast.
So we give him the device and he puts it, he's going to do an SMA angiogram. He's just going to put the device in and do an angiogram. At this point, Jim is in Colorado. I'm sort of calling him intermittently from Australia. It's probably like 2 a.m. where he was, 10 a.m. in Australian time. And he's nervous. Everyone's nervous. How's this going to go? What's going to happen? Dave Liu's there, very curious to see what's going to happen. So he gets the device, he puts it in, and Lawrence, his face, he looks at me and he says, "I can't see it."
Oh my gosh.
Like, what?
It's radiolucent?
Yeah.
Oh no.
It was completely.
There's no markers.
Well, exactly. What happened is I had done all this animal studies in swine.
Oh.
Swine I forget, or just
they're very narrow. Yeah.
Very narrow, even though and you could see every detail with the swine, and then you put it in a human being with,
disappears.
28, it disappears completely.
Oh my gosh. Hey everyone, and welcome to the BackTable podcast, your source for all things endovascular and interventional. You can find all previous episodes of our podcast on iTunes, Spotify, and on BackTable.com. This is Bryan Hartley as your host this week. I'm a radiologist living in Silicon Valley and also co-founder of an early-stage medical device company in the pulmonary space. I am very excited for our special guest today, Dr. Aravind Arepally. This is our next installment in the BackTable Innovation series, where you will hear stories from physician entrepreneurs who are helping to shape the endovascular field through devices. Before we get into our topic today, I just want to say a quick word from our sponsor, RadPad. RadPad radiation protection products, developed for physicians by physicians and clinically proven to protect during cine and digital subtraction angiography. Don't bet your health on anything less. Trust RadPad radiation protection for all your interventions. See radpad.com for more information and contact info@radpad.com to learn more about radiation safety CME credits for you and your team. So with that, I would like to introduce Aravind Arepally, a world-renowned interventional radiologist, innovator, and medical device developer. Aravind has done extensive work in the embolic space and is co-founder of Surefire Medical, now known as Trisalis, a leading pressure-directed therapy device company designed for interventional oncology procedures. Welcome to Aravind.
Welcome, Brian.
Thanks. Yeah. So really glad to have you here. So would love to just start off with, hearing a little bit about yourself.
Sure. My name is Aravind Arepally. I live in Atlanta, Georgia. I'm originally from Georgia itself. I'm a practicing interventional radiologist. I work at Piedmont Healthcare, part of a large private practice group called Radiology Associates of Atlanta. I practice predominantly liver-based therapies. We're a big transplant center, one of the biggest ones, I think, in the country, especially for a private group, and pretty robust practice with both diagnostic and interventional radiology.
So what's your case mix in terms of a diagnostic and IR?
I would say it's mostly 90% IR, 10% diagnostic, and with interventional, I pretty much mostly liver-related procedures because that's pretty much the brunt of our patient volume. We are starting to pick up some early prostate artery embolization. We also have some dialysis volumes, but mostly I would say it's liver-directed work.
Wow. Okay. And so looking at the past a little bit, tell us, how did you get to interventional radiology? What inspired you to do that? And maybe some of the mentors along the way that helped you through it?
Sure. I think, I would have to probably say the thing that really got me interested to begin, I'd have to go back all the way till, I would say, high school, in the sense that my parents, both my parents were physicians, and they were immigrants that came from India. And I remember as a young child, my mom was, she was in residency. She had to redo her residency. My dad didn't have a residency, so he was unemployed. And my mom was working in Philadelphia. And I remember how hard she worked. She would basically get up at 3:30 in the morning, cook a meal so the kids would have dinner, and then go to work around 5, and then take call. And then so we'd at least have a meal on the table. So it's like those kind of things. I remember how hard she worked, and she sort of inspired me with both my parents with their dedication. But the other cool thing is, I think, I grew up in a small town called Vidalia, Georgia, and that's where she was an OBGYN, and you can't do this now, but when I was in high school, I remember my mom would let me scrub in with her.
Oh my
And,
gosh.
and I would be doing, hysterectomies with her,
You're kidding.
No. And it was just, she's like, this is this. And she'd show me the anatomy and she'd show me what to do, all these other things. So it was like a very early experience that you just can't get that now. And, it's a small town, she was, there was 2 ORs in the whole hospital. And you could just do, that was, you have a very immersive experience with that. So,
wow. Any specific things you remember from that? Because that's a very unique experience for someone that young.
Yeah, no, I just remember how respected my mom was in the OR. She was very gifted in the OR. And I just remembered how calm, collect she was. And that was just, you don't know anything in high school, obviously. You don't really, but just to being able to be with her, she's doing her craft, her work, was just imprinted on me pretty significantly. And also seeing, like, she was the only OBGYN in town. And I never, when you're growing up, you don't take this into account, but she was on call every night. And she just never complained. She did it, and then would go to the grocery store, and I'd see all these people coming up to her saying, "Oh, you delivered my son or my daughter," and this is so it was very cool.
That's special.
So those were all special, imprints on me.
No, that's fantastic. Did you deliver any babies or help her with that?
No, it was just surgery.
Okay.
It was like either pelvic or GYN surgery, but
gotcha.
No, nothing like that.
Wow, that's fantastic. That's a great story.
And
so, go ahead.
I was going to say later on, I think what happened is I went to med school and I didn't really know what I wanted to do. And ironically, I didn't want to do OBGYN. I rotated, and I was sort of like one of these 4th year students that was sort of meandering, didn't have an idea. I think I wanted to do surgery, but I didn't want to do medicine. It was one of those situations. And I remember I had to do my mandatory radiology elective. And so I go in there, and at that point in the radiology elective was not well organized, and it was at Emory. You go in and you basically sit in the back room, and then you watch someone read out with someone else. And I was just like,
oh my gosh.
And then the lectures, there was always a lecture at 7 a.m, I remember. And 7 a.m, and then you'd have someone up there talking about chest x-rays in the dark. And half the time I fell asleep. And then one day, this guy comes in the room. And he turns on the lights. He goes, all right. His name was Alan Zuckerman, and he was the head of IR at Emory at that point. He said, I'm not going to show you any cases. I'm just going to show you some devices. And he literally had a box, and he just opened the box, and he spilled it on the table in front of everybody. And he says, come over here. And immediately my eyes just like went wide, and my jaw dropped. And I was like, oh my gosh, this is it. And it was like, I knew this was it. It was like
kid in a candy store.
Yeah, exactly. I was like, this is exactly what I've been looking for. I mean, and he went through all the clinical scenarios. And then from that on, I was hooked. And I would always be, whatever rotation I always end up somehow being on IR, either scrubbing in or just talking to everybody. So for me, it was just a very natural fit. And thankfully, it happened during a rotation randomly. It was not something calculated. So, and it worked out well.
That's fantastic. I think, there isn't, at least before, there really isn't a ton of exposure to interventional radiology. And it always seems, I don't know, the story you described is not a dissimilar experience for me. Is it's almost as if they're trying to get people not to want to go into diagnostic radiology. Exactly. I don't know. It's like, let's learn about a chest x-ray and people reading in the dark and how boring it is. And, it's interesting that anybody goes into it.
It really is. And I think, at least now it feels like there's so much more awareness, whether it's through social media or through SIR outreach programs, it's better. But back then it was just horrendous. I mean, it was just random luck if you got exposed to it.
Crazy. And then, so that was in residency, and
correct.
Is that correct?
Yes.
Or med school, excuse me. That was in med school. And then you went to residency also at Emory. Is that correct?
I went to residency at Emory, and then afterwards I think this is sort of a theme in my life, is I intentionally decided to go somewhere else for my fellowship. I wanted to get a completely different perspective. So then I went to Hopkins for my interventional fellowship.
Okay.
And then from there, stayed on as faculty for about 8 years.
Okay, tell us a little bit about that time. You were director of the Center for Bioengineering Innovation and Design, but maybe before that, when did you start getting into devices? I know you mentioned that great story about dumping the box
Yeah.
of devices, but what happened next what was the next level? What was the next spark?
Sure. I think, there's a couple of sparks for me. I was doing clinical work and that was fine, everything else, but I just wanted to do more.
Mhm.
And I remember I started collaborating. One of the things about Hopkins is the research infrastructure is phenomenal. There's nothing in the world like it. And intentionally started doing more collaboration with people in the MR research division. Now, you would think, has nothing to do with interventional radiology. This is MR research, a lot of basic scientists looking at spectroscopy or looking at, Fourier analysis with reconstruction, how fast can you make the MRI? But this group, and I realized the reason why I went to this group is one, they were pretty much the foremost high intense researchers in the world at Hopkins and radiology. And I wanted to be exposed to some just really high level research. And so I started hanging out with them and I started doing MR guided interventions. And that's when the spark came, where they really pushed me to just think about bigger ideas, pushed me to think about creative ideas. The people, I was surrounded by really smart people, collaborative people, some of the most collaborative people I've ever worked with, very supportive. And that really sort of helped me, I would say, give me my foundations of research skills in the sense that I learned how to write grants, how to write papers, I learned how to do presentations. It's something that unfortunately you don't get taught any of these things along the way when you go into academics. And in fact, I remember even they made me take a course on grant writing and one time, and not made me, but they suggested it. They said, hey, this will help. And again, I had really good collaborators and I took this grant writing course and it was mind-blowingly good. And I was like, I cannot believe that people don't get this, the minute they start academics, because it really teaches you a perspective. And so hanging out with the MR Research Division really helped me with that. But then at that point, by doing that, I met more engineers, I met more people in the engineering school. And so it really broadened my base. And I would say the research with MR research was like creating my foundation and my network of people. And that really helped me move along. And I would say another time that sort of inspired me to even go even further, and this is sort of another crazy story, but I remember one time I was collaborating with a engineer. His name is Perry Kamarker. And he and I designed a lot of MR guided needles that you can visualize and you can track and everything else. But he was also the kind that he's always up for trying something. And so I remember one day I was in my office working on my paper and I was writing a grant or something. And he said, what are you doing today? I said, we're working. He goes, you want to go with me to DC? There is a space conference, privatization of space.
Interesting.
I was like, yes, let's go.
When was this, did you say?
This was in 2005 or 6.
Okay.
So this is very early on. And they had, in Washington, D.C., they had a space conference where they basically were trying to basically innovate the private industry for space, whether it's a space travel or space tourism or anything related to space.
I know somebody who is into that, but continue.
Oh yeah. Yeah. And so I go to this conference thinking, okay, I'm just going to go and this is again shows me how once you displace yourself into a completely different new environment, it can have a huge impact on your life or your trajectory. So I'm going to this conference, I'm walking around looking at all these booths, which is very cool. And back then it was so small, so primitive. I'm sure now it's very, very advanced. And the keynote speaker at that day was Burt Rutan. And this is before he became he's already was famous, but not as infamous as he is now. And he gave a talk and he talked about how he had put more spacecraft into space the last 2 years than NASA had done in the last 20 years. And I remember he made a couple of comments which really resonated with me. One was he said people at NASA, he called them, they're turning tricks. A lot of people, what they do is they basically churn through projects to get more grant money. And unfortunately, I saw that also in academics. I felt like people a lot of times were just turning tricks. And he really said, you really need to shoot for big projects, really big, impactful projects, and don't think of just doing incremental projects. And he was very, influential in my thinking at that point. And so that's after that, listening to that talk. And I remember talking to Perry. I said, Perry, we got to really start thinking bigger projects. And that's when I started, playing around with obesity. I was like, I'm going to just start work on ideas. It may be crazy, but I'm going to work on ideas that are not traditional projects that people have not worked in, more of the blue ocean strategy. And that's sort of how I sort of approached my career and trying to, displace myself into new environments, maybe get some new insight, input, and from there, try new projects. And that's sort of how, from there, I started doing bariatric embolization. Then Perry and I started working on other projects. And then with that, we started really collaborating with a lot of engineers, especially in the biomedical engineering school at Hopkins. And so that's sort of the evolution of my career at Hopkins.
No, that's fantastic. Obviously I was thinking Elon Musk when you were talking about the privatization of space travel. But you mentioned a couple things, principles really that several other innovators have mentioned to me before. Hanson Gifford, who is he's one of the co-founders of the Foundry, the most successful device incubator in the world, based out of here. And Josh McHour, also another big time innovator. He has the ExploraMed Foundry. They both have told me that you need to, and all of us, we were at Stanford Biodesign, you have to think big. And that was a turning point for me when they say something like that. They're thinking attack stroke, thinking these big areas that you can make a large impact.
Yes.
Because even if you miss your target, you're still going to hit something that's impactful. And I think, or at least that's the way I have looked at it.
Exactly.
When I was starting at Vanderbilt, where, you and I met through Reed Omery, but I was working on a device, a new biopsy needle for CT guided biopsy. And I've mentioned this before, but looking back, I'm like, the impact of that is going to be relatively small. It was interesting to work on and I learned a lot, but now that my eyes are a little bit, I think my vision is broadened a little bit. And I think it's great advice to say, don't be afraid to think big and attack big problems or blue ocean problems. Blue ocean meaning where there are very few competitors, where there really aren't any devices that have been in that area.
Exactly. I mean, that's so critical. I mean, because, and the problem is sometimes we end up getting tunnel vision with our areas, and what we think is a big project problem may not necessarily be a big problem. So
that's right.
It's really important to expand your horizon and expand your input and get ideas from other people.
And, you mentioned your engineer, his name was Perry, I believe you said. And
Yes.
One other thing that kind of sparked my thoughts was you said he was always up for trying new things. He's the guy who always said yes to things.
Yes.
And I think that is so important that, well, first off, developing devices is it's a team sport. You can't really do this on your own, at least from what I've seen.
Yes.
Maybe you can have somebody who's a jack of all trades, but having a partner who will build upon ideas. There are too many people that will hear an idea and be like, oh, that's not a good idea, or oh, that'll never work. Those people can be really tough to innovate around, or to allow the space for creativity.
Yes.
And it sounds like that's kind of the experience you had.
That's true. I mean, I also, I've talked about this also in general with fellows and residents, but I find like there's in life, and it's not even about innovation, but in life, there are people that give you energy and there are people that take energy away from you. And like classic Perry, Reed, Omri, people that are surrounded, they are the people that kind of give me energy, and they're always willing to listen. They're always willing to try, or there's not, it's the no word is not part of their vocabulary. They're always willing to, but they're also willing to challenge me too. They're like, I mean, for the longest time, I mean, these are some of the crazy ideas that Perry and I have had. I mean, one time we were sitting there working on the schematics and designing a MRI machine for space, I mean, it's just, it's crazy, but at the same time, but those are the kind of exercises that we need to do mentally or,
absolutely
interactively. Sure, they don't go anywhere, but at the same time is they sort of create these collaborations and create, it's like kindling fire. It's just
totally.
That's why I feel about it.
Kindling fire. I like that one. But it's creating the space so that, I mean, maybe you aren't going to do anything in that area, but it definitely stretched your intellectual muscles and your creative muscles that maybe pushed you in other areas, such as, when you were developing Surefire.
Yes.
When you were working on Surefire. But before we get there, you've had some good, interesting experiences. When did you start working on bariatric embolization?
So I started working bariatric embolization around 2006, right after that Burt Rutan lecture. That's when I started doing the research and started really trying to dive into obesity, trying to dive into all the minimally invasive procedures. And that's when I started realizing, I remember there were a couple of key papers that came out in New England Journal, as well as other publications where they showed that there's a high concentration of ghrelin within the gastric fundus. Mm-hmm. And I remember that there were people trying to modulate ghrelin levels to sort of, impact the appetite and suppress appetite, all these other, so there's all these pharmacological methods people were using. And I remember, obviously with interventional radiology, I'm like, well, the gastric fundus is something, there's a conduit for us, which is the left gastric artery. Mm. And that's when I had grant money from other areas, and I started putting in money in. I started applying for grants for this, and got some funding. And to be honest, a lot of people were, is always saying this is crazy, but that's fine. And
there you go.
Barry and I started playing around with it, and then I had, various other papers come out from it and showing that we could suppress ghrelin level by doing some blind embolization. I went through all kinds of embolic agents. So it was not, it wasn't easy, but at the same time as the experience I had from the MR research division on writing grants, writing papers, hypothesis driven research, these are all things that sort of helped me craft the basic science for this work. And that was, that was a lot of fun to try to sort out, tease it. And then we actually were able to take it from concept, preclinical, and did some clinical trials, and we're still on the clinical trial side of that. But it's, that's the things I feel like I'm proudest of, is I took an idea purely from a concept and did the research, the basic science, the preclinical and the clinical aspect of it, and carried it through. And that in itself, even if you don't have let's say the trials don't completely come out successful, to me it's a success because I went through the entire exercise of doing it correctly, properly, and trying to vet out what works and what does not work.
Absolutely. Not everything's going to be a grand slam, but, do it safely and explore new concepts. And I think this one makes a lot of sense. And the trials are still ongoing. Is that correct? Is that the BEAT trial?
Yes, exactly. The BEAT obesity trial, basically bariatric embolization of the arteries to treat obesity, basically. Yes. So that's where we are. Part of our struggle right now is getting funding for the trial. We're working on different mechanisms. Cliff Weiss at Hopkins is spearheading it now. From my standpoint, I just don't have the bandwidth for all the clinical work to do that. But Cliff is sort of spearheading it that. But yeah, there's a funding mechanism we're looking at, and to sort of expand it.
Very cool. And in 2007, you were in Germany. Is that right? And what was that all about? You were working with Siemens. How did that come about?
I would say that was a very pivotal point in my career. And I think it's funny. I was listening to your podcast with Mike Dake, and I remember he went to Italy. I kind of feel like for me, it was the same thing. At that point, I was working in the MR research division, and the opportunity came for me to do a sabbatical in Germany with Siemens in Erlangen, which is in Bavaria. And I took them up on it. It was basically a 4-month sabbatical from my practice, and I went there. And to be honest, Brian, it was probably one of the best times of my life. With my daughter was 2 years old, we lived in this tiny little apartment where we converted the one bedroom to made her bedroom, and we converted the living room to a bedroom. I had, when I got there, Siemens gave me an apartment in Erlangen, which is an old university town in Europe, gave me a bike, and then they gave me an Audi.
Wow.
But I barely used the car because I walked or biked to work every day. We were across basically 2 blocks from the train station. So we were in Central Europe, so we can go anywhere in Europe within 2 or 3 hours so easily. And I worked with the MR engineers at Siemens. I traveled around Europe. I met a lot of interventional radiologists in Europe, got to talk to a lot of MR guided intervention. So really, for me, it was nice because it pulled me out of my current environment, expanded my horizon significantly, got to meet all kinds of cool people and also learn about industry. That's something I was lacking too. I sort of, the Siemens people were very, very generous in the sense that I didn't speak German. They spoke English and German. So a lot of meetings, normally they do in German, they did in English for me. I got to present to the board at Siemens. I got to go through a lot of interesting meetings and giving them some input on other imaging equipment. So it was a very fast 4 months, but it was also extremely enriching for me. I just learned a ton, and also we had a great time living in Europe.
Oh, that's fantastic. It does seem like sometimes making big changes like that can open your mind to other possibilities.
Yes.
They can be pivotal. So you left Hopkins in 2008
Yes.
or around then, and you went to Atlanta, and that was to a predominantly private practice. Is that correct?
Correct. Yeah.
Okay. Yeah. And that's where you are still today. So I have to ask, how did you keep up you're an innovator. How did you keep up with innovation and do private practice? I know there can be a lot of demands. There are a lot of demands in any practice.
For me, I think part of the reason why I left academics, I wanted to put myself in a totally different environment. I mean, and I feel like this is sort of a recurrent theme in my life, but just being in a completely different environment for me, it gets the creative juices going. It allowed me to reframe everything. It allowed me to look at different challenges and see what the problems are. And innovation to me is more of a mindset. So like academics is a mindset. You can, as long as you have the right time, the right ability and time, and surround yourself with the right people. And so as soon as I got to Atlanta, I really started surrounding myself with, trying to find the infrastructure that was available in Atlanta. There's a Global Center for Medical Innovation, which is at that point, a very early stage medical device group. I met with other, innovators around the city. So I just tried to, and Georgia Tech also has a phenomenal infrastructure. So I basically reached out trying to find different people. And at the same time, I wanted to sort of put myself in a different environment to sort of, to get my creative juices going. The other thing is, when a lot of physicians talk to me about starting companies or devices, one of the things you need more than money is really time. And that's probably that's your biggest enemy, time. And I remember at that point when I joined Piedmont, we had a lot of good time available. And it was also more like flex time in the sense that I could work as much as I wanted and have, you could buy your time off as you want. So it was not a rigid schedule, which was nice. It was more of a flexible schedule. And that worked for me. And the good thing is I already had, as I said, the basic foundations at Hopkins and the MR Research Division of writing grants, of writing papers and doing the research. So I felt comfortable doing all that stuff. And I think this was more of trying to balance my family life, my clinical practice, and my academic time.
So give me an example. Were you working 3 days a week? How was it?
Yeah. It differed. I mean, week to week, some days 3 days, some days 4 days.
Some weeks.
Yeah, exactly. Sorry, some weeks, at a time. So it varied. And, you also, you use your weekends, you use other times. So evening times, especially when you're starting a company, it's going to be a lot of evening times, a lot of weekend times, a lot of,
Absolutely.
No matter whether you're in academics or whether you're in private practice, it takes a lot of energy. It's a lot of fun and it's extremely satisfying. But at the same time, is people, I think, totally underestimate the amount of time it takes. And I had, it's funny, I worked with a startup when I was in the MR Research Division, and the CEO of that startup, his name is Kim Jenkins. He's over in Memphis. And when I started with Jim Surefire, he's the one that told me the same thing. He goes, Aravind, time is your most important asset you have right now. When you don't have money, you haven't raised any money, you have to figure out how to optimize the use of your time. So, because if you don't do it right, it'll fall apart.
That's too true. And with that, I think that's a great segue. I'd love to hear about the origin story of Surefire. Who were you with? How did you come up with the idea? What was the clinical need behind the idea?
So I think we can say the origin of Surefire can boil down to a book that we would I would recommend to anyone, and you probably know about it. It's the biodesign book from
Oh, yes.
Paul Yock and Josh Mycauer. Basically, we follow that approach. So Jim Chomas is, and as you said, is that it really is a team sport. It's not an individual situation. But the way we started, Jim Chomas and I, Jim was at the Foundry. He was worked with a startup company called Cabishon. He had left in the Bay Area and he wanted to start a company. We met through a mutual friend of mine in the MR research division. His name is Wes Gilson, who happened to be Jim's grad school roommate. So anyway, Jim and I met and we actually approached it through the biodesign approach, which is basically try to find the clinical need, go through the process, and really we followed it to the T. And when we did this, and actually about a year after we did it, I actually emailed Paul Yock and thanked him and let him know how appreciative it was, because it really was very helpful. Because, and I tell this, and I tell people all the time is, and this is one of the books to get, is if you're going to do something from start like this, the biodesign approach is really helpful. I mean, you just sit down, you go through the clinical needs, you write down all the clinical needs, you go through the process, and it's as you well know, Bryan, it's a well-organized process. It provides structure to something that can easily devolve without structure. So
something that's what you would normally think is amorphous,
Yes.
is innovation. It's the light bulb that goes off when you're in your shower. That's the common thought about innovation. But they have done something special at Biodesign, and it is a repeatable process, and it does provide structure framework so that you can do it in a way that you feel confident you're on the right path, I think, because it's such a hard path that a lot of times you question what you're doing.
Yeah. And the other thing is, I think it's important to know is when we started Surefire is that, and this to me was one of the funnest part is Jim and I, we wrote out a business plan. And to me, writing a business plan was like writing a grant. And he and I did a deep dive into everything out there about not only the clinical need, but what is the current literature about all this? What does it say about non-target injury? What is the solutions that people have? Then we looked at the business concept. What is the market size? These are all, again, things that were in the design book. So,
and you didn't have an invention yet, or you're still working on the need, or you had some ideas?
We had some ideas, yeah, but we first worked on the need, and then once we had the concept of the valve, then we expanded it. And I always tell people that if you have an idea, I think it really is a good exercise to write out a business plan, because that putting down into words on a paper your thoughts, it really helps you go through the process. Things because too many times people have ideas and they just want to run with it. But if the sitting down writing a business proposal really slows everything down and makes you think about the details, the nuances, what is going to be needed, all these other things.
That's a great idea. And it also tells you how much work it's going to be.
Yeah.
So you can be honest with yourself.
Yeah, exactly. And, and my friend Kim Jenkins also said the same thing, is whatever you think you write in your business plan is going to cost double the amount and double the time.
Yeah, right.
Whatever you think, just double everything.
Just add in the unknown X factor. Yeah, times 2.
Exactly.
So you came up with the idea of the valve, and was that a team effort? You said
Jim Chomas actually came up with the idea of the valve. So
gotcha.
This is sort of an approach where, again, the collaboration where Jim and I had such perfect complementary skill sets. Jim was really good he was a biomedical engineer. He was on the engineering side aspect of it. He understood, the engineering. He understood how to write patents. He actually understood the business side of it. I was very comfortable on device development. I was comfortable on the clinical need, obviously, and writing scientific papers and doing research. So he and I both had really good complementary skill set. And so I said, Jim, we need to have a device that's going to create antegrade flow no matter what, because we can't have a situation we're trying to embolize, because all you do is if it creates sluggish flow, you need to have further antegrade flow. And so he was the one who said, well, let's do a valve. And I was like, wow, well, that could be hard, but
in such small spaces.
Yeah, exactly. But that's how it all, sort of came together.
Oh, that's great. So how'd you test proof of concept? When did you raise funding? How far in did you say, all right, we have something, let's pitch this to some investors? Did you go to angels or VC or grants?
You sort of like, as you know, with startups, you have several parallel tracks running. You have basically your research track running, R&D. You got the regulatory track running. You got basically the fundraising arm running. So you basically got to do everything, and especially when you don't have money. So, Jim and I initially threw in money together to start the company.
Okay. You seeded basically yourself. Okay.
Right. And then with me, I found obviously in Atlanta a place here that does animal research where we could do the proof of concept. Clearly, we set up a scientific advisory board, all the small infrastructures you need to do first, which is basically incorporate the company. We had a little office in Boulder, Colorado, which was in a internet service provider, which was a little closet in an internet service provider, Boulder. And I would fly out there, and Jim and I would work in there, and we'd write the business plan together.
Okay. And
then basically and do all these other steps together. And then these are the days of, we use Skype to sort of talk about things, and would go fundraise. We went out to the Bay Area, Life Science Angels. We gave a pitch to them. We went to Manhattan, gave several pitches there. We just sort of reached out to multiple things. I mean, a funny story is one time I remember at that time, my daughter, was sort of in preschool. And there was one day, and so we were living in this tiny apartment. We just moved to Atlanta, and we were in this apartment. And Jim and I would do Skype calls all the time to sort of coordinate and everything else. And I remember one day I was going to San Francisco to meet with Jim, and he and I were going to present to Life Science Angels. And I took my daughter to school, and I dropped her off. My flight was like 10 in the morning. And I dropped her off. My daughter walks up to the teacher and says, "My daddy is flying to San Francisco with a man he just met on the internet."
Oh, I'm sure that went over well with the teacher. No phone calls, no PTA meetings after that.
And she was just like, and she had never met Jim, but she just knew it was a man on the internet.
Oh, man. Very smart girl.
Yeah. But anyway, so we did a lot of fundraising that way. We did the proof of concept in the animal study where we basically went into the kidney of both swine and gave a standard microcatheter and then the Surefire device, and just to show the non-target with 10 feed. So those are all the proof of concept we went. And then our first initial investor was a guy named Norm Weldon, who's in Boulder at that time. So we pitched to Norm. Jim and I had, we'd done so many at this point where, we were on autopilot, and that I would start and then Jim would start. And I remember we started one pitch with Norm was in the room, and his partner, Karen Cassidy, was in the room also. And about 5 minutes into the pitch, I mean, barely title slide, barely into, the clinical need, Norm pauses me and he says, "I just want to let you know, I am not going to invest anything on this, but go ahead and go."
Oh my gosh.
And we're like, okay. I was like, so then
what do you do? What do you do at that point? I guess we'll keep going.
Yeah, exactly. Keep pushing. And it's funny. It was supposed to be a 45-minute meeting. And then an hour and a half later, Norm is still there asking us questions. Karen is like, "Norm, we got to go. Norm, we got to go." And Norman ended up, he just wanted to see how we'd react, if we would become belligerent or if we would.
Unbelievable.
And, Norm ended up being our first investor. Great guy. He was a former CEO of Cordis.
Oh, wow.
He was a tough guy. And he just wanted to sort of push our buttons to see what it was like. And, but in the end, Norm invested, but not only that, but Norm was an incredible advisor for me and Jim, especially for Jim, because Jim was a new CEO. We had devised up the company when Jim and I started where he would be the CEO and I was the CSO. And Norm living in Boulder was great because Jim could reach out to him, and Norm then had a lot of network of contacts. So it's really, that was very helpful from that standpoint, having that.
Yeah. So Aravind, maybe you can tell us, was Surefire always successful from the beginning, or did you have any failures or any trouble spots along the way?
There's always.
I know the answer to this question.
Yeah. I mean, it wasn't like there were always issues. I mean, but I'll give you a highlight of a couple of really big challenges that occurred, which was some of these were funny in a sense. So at one point in 2011, we're in Miami, we're cranking away, we're starting to do the device, prototyping the device, basically design freeze, everything else, and we had reached out to all the companies like Certex and at that point Nordion, telling them we're working on a catheter for anti-reflux, all this. And I remember Certex approached us and said, would you guys be able to do first in man study in May? And again, this was in February.
Okay.
And we're like,
well,
we just said yes.
Yeah.
And because Certex was an Australian-based company, and there was a mechanism available in Australia where if you have a sponsor, you can do a first-in-man study.
Right.
And so at this point, the engineering team, we all gear up to get it ready to sort of submit to FDA and get a design freeze. So we barely got, and this was Memorial Day 2011. And I remember we said, okay, and that was the target date. So I basically flew to Australia for a 4-day trip to do a first in man. And we got the device, we got everything ready. And then basically, at this point, I didn't really understand international issues with imports and export taxes, all that. But I go through several funny stories in Australia. I land, it's just me. And I land in Sydney, Australia, and I'm going through customs, and then they say, do you have anything of value? The usual questions. And I said, I have medical devices in there. And then they immediately start saying that there's going to be a tax based on the valuation of the company and the devices. It was crazy.
Wow.
It was going to be like, so finally I had to backtrack quickly and just
say,
no,
not a medical device. This is research purposes only.
These are exactly research purposes. So anyway, so I go to St. Vincent's Hospital and where Lawrence Bester is an interventional radiologist, works closely with Certex, has offered to do the first in man. And Dave Liu in Vancouver at that point was the medical director for Certex. And I did not know Dave at that point. And Dave flew from Vancouver to Sydney because he heard about Surefire and he was interested to see how it worked. And again, Dave is an interventional radiologist, but I did not know him before that point. So that's when I first met Dave. And Dave and I just clicked. He's an incredible person, extremely bright, very smart. And again, like one of these people that gives you energy. And so anyway, we go to do the first in man. Here I am jet lagged. 10 in the morning, we go in. Lawrence Bester, I said, let's do the first in man in a planning angiogram. So let's put the device in just a standard diagnostic angiogram. You're not going to do anything. I just want to get some pretty pictures.
And this is, just to be clear, this is the anti-reflux catheter. This is what you're using it for.
Yes, the early prototype.
To prevent non-target embolization.
Exactly.
Okay.
And so I gave him it was all packaged, sterile, everything, all good. So and then, in Europe and Australia, it's a lot different. And they're like, you want to come in and scrub? You can come in. I was not.
I've been scrubbing since I was 13 years old. So.
Exactly. But I said, no, I'll just sit back, Lawrence. Just too many, conflicts here. I just want to just let you do it. And then I'll just sort of. So we give him the device and he puts it, he's going to do an SMA angiogram. He's just going to put the device in, the Surefire device, and do an angiogram. At this point, Jim is in Colorado. I'm sort of calling him intermittently from Australia. It's probably like 2 a.m. where he was, 10 a.m. in Australian time. And he's nervous. Everyone's nervous. How is this going to go? What's going to happen? Dave Liu's there, very curious to see what's going to happen. And then also David Cade, Chief Medical Officer for Certex, is there. So he gets the device. He puts it in. And Lawrence, I remember his face. He looks at me. And he says, I can't see it.
Oh, my gosh.
Like, what?
It's radiolucent?
Yeah.
Oh, no.
It was completely.
There's no markers.
Well, exactly. What happened is I had done all this animal studies in swine.
Oh.
Swine I forget, or just.
They're very narrow. Yeah.
Very narrow, even though they're. and you could see every detail with the swine, and then you put it in a human being with,
Disappears.
28, it disappears completely.
Oh my gosh.
And so we had to and then so he's like, it's okay as long as you think it works. I was like, well, it works. So we did some contrast runs. You could see the negative defect of it.
Right.
And then he goes, all right, that's fine. We'll do it on the next case. The next case it was a case where basically he had coiled the GDA, and then part of the coil had extended out into the right hepatic artery. And was basically partially occlusive. He goes, I want to use it in this artery now. And I'm like, oh boy.
Oh.
But, and again, I was like, here we go. We have a partially loose coil. I'm going to be this catheter in there.
Not how you wanted to start the clean scenario.
Yeah. But it worked well there. It worked great in the sense that functional. We just couldn't see it. And then so we just had to add markers, to visualize it, radiopaque markers. But anyway, so those are there's just things,
little things, but you have to think about when you're innovating. I mean, they become critical, but at the time, it's just another small detail. God, that's crazy. So
but it was also, I think the other thing, and you probably also noticed this, but the whole surefire path with the process we had done, it's also the people you meet. It's obviously me and Jim are really good friends. Norm Weldon, the CEO, I got to meet all these people around the world that were using the device and trying to get experience with it. Dave Liu is a good friend of mine now. He and I are close collaborators on other papers and projects. So it's just, that's the part of the thing I really enjoy about this whole startup process, is the people you get to meet and collaborate with, because they're very like-minded. They want to do stuff. They want to, they're willing to, push the envelope in ideas.
It's I cannot agree more. I say that's the one thing so far. I mean, you've achieved success, so we're still working on our stuff on our end. But my co-founder and I mean, the relationship you develop going through these trials and tribulations is by far the most rewarding part, at least so far. So I totally agree.
Yeah, and you have to find the people. You really have to be careful who you work with, because if you can't get along with someone like this, because something like a startup is so intense,
it is
so much of a time commitment. You really have to make sure. And actually, it's funny, when Jim and I first met, we actually basically we got to know each other, made sure we could get along with each other, and it just turned out he and I are very like-minded in our approach to things and very laid back. So it was good. It was a good fit.
Yeah, it's not always going to be a perfect fit. I think that is just clear from the beginning, and everybody goes through instances where you just have to say, hey, this isn't working out. That's also a very important part of a startup, and making sure that you continue making progress. So tell me, Surefire is successful. You guys have done very well. You've commercialized, and it's out there. Surefire, where is it now? Where is it?
So it's TriSalus. It's becoming, Jim and I moved from anti-reflux to really trying to improve the device in several ways. First is it was not easy to use. So we really try to streamline how well it can be utilized with the workflow. We changed that aspect of it. And we actually started moving towards trying to do pressure-directed therapy, in the sense that we want to try to modulate, control, improve therapy, more penetration into tumors itself. And that being said, it's gone along that. He and I also started working on the pancreas and doing pressure-directed therapy for the pancreas. And so along those lines, the company has moved. So Jim and I both have left Surefire. TriSalus is now moving in those kind of directions with the pancreas, pressure-directed therapy, and we're also working on some pharmaceutical therapies alongside of it. So it's sort of now, it's a ship on its own now.
Got it. That's fantastic. I think
I've stepped off, but it's been an incredible journey.
That's unbelievable. Now, anything else in the pipeline for you? Anything you're working on?
I'm at that stage right now where I've moved on from TriSalus. I'm actually in the stage of now going back to working on clinical needs and working on a couple of ideas. I still am very, very interested in the pancreas and pancreatic cancer. So looking along those lines and that's
a rich space to look into, and
yes, exactly.
Definitely lots of needs there. That's the fun part to me, is getting into the needs.
Yes.
The possibilities are endless when you're in that phase.
And I go through this, and I used to do this. I'm going to start doing this regularly, but I used to take a day off just completely detach from the grid and just read all day of a certain topic, and just
PubMed, you're just cruising.
research. Yes.
Got it.
PubMed, anything. Ironically, I found all kinds of interesting. If you just type in pancreatic cancer in Twitter, for example, you see all kinds of things that people are working on. So that leads me to different things. But sometimes I've done that, and I'm probably going to do that again over like a weekend where I just sort of do a deep dive and see what's going on, where people are, and then there's looking at other startups and just get ideas on that. So that's the situation I'm in right now.
That's great. You mentioned social media. I've always been interested to see if social media could be used to leverage to find clinical needs, because it's really, you can tap into both the patient population, maybe patients who feel left behind, and then also physicians, other innovators. That's a very rich platform to dig into. I think that's very interesting that you mentioned that.
Yeah, it's funny because if you just type in anything I tend to use Twitter. I have not used Instagram or Facebook or anything else, but it seems like Twitter has more of a medical bent on it in some of the areas. And so when you type in certain topics, I'm always surprised about papers that come up. And I think, we should also, on the other side, we should also try to promote more papers we publish on Twitter to sort of further, as an outreach, because it sort of helps, let everyone know what's going on in that space. So.
No, that's great. I think that's a great place to leave it. So, Aravind, thank you so much. That was a pleasure. I really enjoyed chatting with you and hearing your story. It's inspiring for sure, and a lot of good stories, a lot of good advice in there.
Well, thanks a lot, Bryan. I'm very impressed with what you, Aaron, and Kieran have done with BackTable. It's just an incredible organization. So congratulations to all three of you, and thank you for the time to chat with you guys.